like to welcome you to Impact Education's PayerTalkCE program entitled Managed Care Strategies to Improve Outcomes for Macular Telangiectasia. Because of that, I'm just going to refer to this as MacTel for my own sake for the remainder of the program. Today's program is jointly provided by Partners for Advanced Clinical Education and Impact Education LLC. The activity is supported by an independent educational grant from Neurotech Pharmaceuticals Incorporated, and we would like to thank them for their support. My name is Jeff Dunn. I am the CEO and president of Cooperative Benefits Group, which is a transparent pass-through PBM located in Salt Lake City. And I am joined today by Dr. Chhablani, and I will have you introduce yourself.
Hello, everybody. It's a pleasure to be part of this interesting program. I am Chhablani. I'm a retina specialist for the last 15 years. I'm director for clinical research, as well as I head the AI lab at UPMC Vision Institute. And today we'll be talking some interesting aspects about macular telangiectasia, that is MacTel, focused on early detection as well as the newer therapies which is coming along for our patients. Thanks.
Thank you. So before we begin, we have a few housekeeping notes. To receive continuing education credit for today's program, you must complete the evaluation form. And your feedback is super important for us. We use it to continue to improve the programs that we do. So we really would appreciate you filling those forms out. So at the end of this program, we should be able to describe the natural history, disease mechanisms, and clinical goals of timely treatment of MacTel. We should be able to review the safety and efficacy data for current and emerging MacTel treatment options, describe the value of multidisciplinary care approaches for patients with MacTel to improve patient outcomes and coordination of care, and finally, we should be able to identify benefit design strategies that ensure access to appropriate and effective MacTel therapies. All right, so we'll now jump into the first formal presentation. So the question I'm going to ask you here before we jump into this is, there have been considerable advances in recent years in understanding this disease and the pathophysiology. So what could you share so payers better understand it?
So this disease, as you can imagine, it is one of the most intriguing disease where, we still don't know the exact mechanism. But luckily in last decade or so, we figured that initially we thought this was a vascular disease where, many of these patients have associated diabetic retinopathy. So we thought that there was a vascular component. But in last 15 years, we learned that there is primarily a neurodegeneration, which is playing an important role in this disease. And that's why we see that this disease has a very slow progressive nature, and that's why the upcoming treatment have been directed towards reducing the neurodegeneration, which we will be discussing in the second part of my presentation. So mostly I would say at this point we all understand and believe that neurodegeneration is the key in this disease. So our all treatment modalities have been directed towards reducing the neurodegeneration. All right, so let's start with my presentation on natural history and underlying mechanisms of MacTel. As you all are aware that MacTel is a rare disease of the retina. So the macula is the central part of the retina, and there is a smaller area at the macula called fovea, which is pretty much a 500 micron diameter area, which defines our 20/20 vision. And very uniquely, this area of the fovea is not supplied by retinal vessels. That's why there is something called as foveal avascular zone. And in particular disease such as MacTel, which is considered a neurodegenerative disease, you will end up seeing the cystic degeneration or the cystic cavitation of the retinal layers involving the parafoveal area in the beginning and then eventually involving the foveal area. And we are going to discuss a little bit more about the role of Muller cells, which comes here, because as you all are aware that Muller cells are very much, we call them as a structural support of the retinal tissue, where you can see these blue lines, which are blue cells, which are Muller cells. They are extending from inner part of the retina to all the way to the photoreceptors. They actually provide a homeostatic, metabolic, and structural support to the tissue. And this is the layer which actually releases the neuro-CNTF factor, which supports the neural activity of the retina. And in MacTel, this layer primarily gets affected because of the reduction of CNTF. So as we were discussing earlier, that what are the common symptoms of MacTel? Many a time these patients have no symptoms. They have come just for a routine eye exam. They can have blurred or the distorted vision, or the central vision is affected over a period of 10 to 20 years. You will see these patients being 20/20 and their disease is progressing slowly. They are falling from 20/20 to 20/30, 20/40. They don't come to you with a sudden vision loss. That's why it is very important to diagnose these cases much earlier in the disease process so we can offer them treatment, which we will be discussing in subsequent slides. So like we discussed earlier, that it does not affect the peripheral vision. So therefore, and it just affects the central vision. That's why it never leads to total blindness. But these patients are usually on a younger age group, so they do have complaints of difficulty in reading vision. MacTel types could be of type 1, type 2, type 3. Type 1 is usually which affects one eye, which is present since birth. It is more common in males, and it can be associated with something like called as Coats disease. When we say MacTel, we pretty much limit our discussion towards type 2, which is the most common disease, which is affecting around 0.1% of the population. It is a bilateral disease. It is possible that the patient can present to you with an asymmetrical disease presentation. One eye can have a slightly more advanced disease and the other eye could be normal. And the usual age group which comes to our clinic is between 40 to 50 years. And many of the risk factors which have been shown to be associated, not necessarily a causal relationship, such as smoking, high blood pressure, or diabetes. So type 2 is the one where we will be pretty much focused in rest of the meeting today. Type 3 is a very rare disease. I've seen probably one case in 15 years, which is like bilateral disease, extremely rare. It is often associated with conditions where there is an obvious capillary ischemia in other parts of the body, including brain. So like we were discussing about MacTel pathophysiology, where the neurodegenerative processes plays an important role. There could be vascular inflammation, vascular occlusion, as well as some ectatic capillary changes. This is a perfect example of a MacTel case where you can see a 58-year-old woman who presents with a slight change in vision, where you can see that there is a right angle vessel which is shown as a yellow arrow on figure A. When you get a fluorescein angiography of this patient, which is shown on figure B, which clearly shows these telangiectatic vessels temporal to the foveal area, which will be leaking in the late phases. But very characteristic you will see on the OCT, which is a very useful non-invasive test which we can do very easily in our clinics, which clearly shows there is a thinning of the retina involving the central area, and there is a cystic change just below the foveal area. This is another example of a 59-year-old woman where you can see that the central area has cystic change right in the center, where you can see this black hyperreflective area, and you see that the fovea is actually thinned out. And when you look at the color photographs, you barely see any changes, just slight changes on the color photograph and slight few telangiectatic vessels on the fluorescein angiography. So that clearly says that this disease is very subtle when they present to us in terms of the symptoms, as well as in terms of the imaging. That is where our expertise is required to diagnose this disease much earlier. The same patient left eye, where you can see there is barely any changes on the color photograph on fluorescein angiography, but you can see that there is a cystic neurodegeneration already affecting the central part of the fovea, and these are the cases which we should be really aiming to diagnose at much earlier stage, like this example.
I wanted to ask you to help us understand something. So I would say payers are not going to know much about MacTel. This is a new disease state for us. We are pretty familiar with other, I would say, for lack of a better description, other kind of related disease states like AMD or diabetic retinopathy, because we've been managing those drugs, bevacizumab and those types of medications for a long time. But is it true that a lot of the comorbidities are very similar here? So when we talk about things like diabetes, hypertension, obesity, those types of things, those are also contributing factors to MacTel as well, right?
So it is very important to diagnose this disease, because many a times this disease is misdiagnosed with other diseases, and very uniquely these patients tend to have diabetes, but it is possible that they don't have diabetic retinopathy, but they have MacTel. And many a times there is a possibility that these two diseases are coexisting. So I know that we talk about AMD all the time, and we have learned so much in last 2 decades about AMD, but at the same time, we have to understand that this disease usually presents with in association with other diseases, like for example, a patient with hypertension, like you mentioned, will come to you for a routine exam, and there could be hypertensive changes in the major arteries, but if you look carefully, you might actually see some neurodegenerative changes, which is because of MacTel. So I think that this is very important for us to educate all the players in the game, because these patients are being seen by endocrinologists, these patients are seen by optometrists. So I think that this educating everybody in the system is very essential, because now we have some treatment options available for this disease, and earlier we identify this disease, we can offer better treatment for our patients.
Perfect. And we'll talk about treatment here in a minute. I think it's going to be super important to understand this as we get into that, kind of what works and what doesn't. So I'm looking forward to that conversation. But to follow up on what you just said, these patients are seeing a lot of different providers. So from your perspective, when they come to you and you've determined they have MacTel, but they have all these other things going on, how do you address that? How do you coordinate that? I mean, are you treating the diabetes, or are you trying to coordinate with a primary care physician? How does that happen?
So we tend to do, because we are on the tertiary eye care system level, so most of these patients have come to us as misdiagnosed cases.
Okay.
That they were being injected for something and they don't see the benefit. Many times these patients are coming just for diabetic retinopathy screening, and we end up diagnosing them as MacTel. But I think that if we really go back into the whole system, then I think that the most important people who need to know about this disease could be endocrinologists, or could be optometrists, or even their PCP, because we need to really educate them that if they are complaining of any vision loss, or if they are not, even if they are asymptomatic, it is very important that we screen for MacTel. And nowadays we have very advanced imaging ways, or simpler, I should say, very advanced non-invasive ways of diagnosing this disease. And the optometrist colleagues are also very much trained to utilize these imaging modalities. We just have to train them.
Yeah, I think the misdiagnosis thing is super important for my payer colleagues in the audience to understand that, and especially as we get in, like I said, when we get into the treatment options here and look at the data to understand that. So that misdiagnosis comment and being maybe treated with the
anti-VEGF,
VEGF, which is not going to be appropriate. Again, I'm teasing here.
Yes.
We're wasting a lot of dollars, but time, and we're causing potential side effects that are unnecessary. Okay, perfect.
Absolutely.
So I'm going to put a little plug in now for something we're going to come back to in a few minutes, and that is the role of the payer in that, because the integrated care managed approach, that if we do it right, can be super valuable. And also, as we know, there are quality metrics, not necessarily around MacTel, but around eye exams and other things as we're managing our diabetic patients. And so this is something that we have an opportunity to educate ourselves about and do a better job to help treat our patients. So speaking of that, can you comment quickly on any screening recommendations for patients who are at risk? I mean, how should we be communicating to providers in general, say the endocrinologist, or even payers, to what's appropriate here from a screening perspective?
I believe that eventually it is going to be as close as we talk about diabetic retinopathy, because diabetic retinopathy screening is actually initiated at the level of endocrinologist, and this disease have a significant association with diabetes. So I would say that if we can educate our endocrinologist folks that this could be a disease which your patients are having, and just pass it to the optometrist for screening, this could actually be very helpful to identify these cases at a much earlier stage. Other than that, I think that any systemic disease, yes, we believe that hypertension also has an association with this. This also could be one more thing that, our optometrist colleagues can help. The biggest challenge is that, when we really talk about screening, then screening is nowadays very much limited to the optometrist, because they have the cool gadgets which our PCPs are not willing to take it. So I think that it is very important that they refer these patients to optometry, who can actually help them to screen for these subtle diseases.
Right, thank you.
So let's talk about safety and efficacy data for existing and emerging treatment options for MacTel. So I've been a retina specialist for 15 years, and I have made multiple mistakes. I have treated my patients with MacTel with anti-VEGF because we did not have any treatment. There was a very, I should say, a controversial data from Germany coming from other parts of the world where some papers are showing there is a response to anti-VEGF, there is no response to anti-VEGF, and that is where I started in my interest in this disease, that why do some patients respond and why other patients don't respond. So let's talk about dividing this disease into two sections, that is non-vascular and neovascular. Non-neovascular and neovascular. So when we really talk about non-neovascular disease, and I have evidence of these patients being treated with lasers, and the lasers were done because there was a leakage on fluorescein, and I have not done it, but people believed that by doing the laser, we'll reduce the leakage, and eventually, because of neurodegeneration, these patients actually had progression of vision loss after laser. So luckily, we learned this after maybe 10, 15 years, and I was towards the tail end of that, so I never did that. Intravitreal anti-VEGF were also used to treat that leakage which is there even in non-neovascular component, which again showed no efficacy. People have tried steroids considering because there is leakage, there is cyst, but this cyst is because of neurodegeneration. And this all, you can understand that it took us almost 10 to 15 years to understand that there is a neurodegeneration which is causing these fluid-filled, or I should say the hyperreflective spaces. There is thinning of the retina, there is leakage, but there is no actual activity. So that's why there is nothing effective till now for non-neovascular cases. For neovascular cases, yes, if you have a documented subretinal neovascularization, then you will be able to get good success with intravitreal anti-VEGF injections, but this is very much treating only the neovascular component because you are still not addressing the primary disease, which is MacTel, which is a neurodegenerative disease. So treating your patients with anti-VEGF injections is not sufficient to treat MacTel per se, but you are just treating the complication of MacTel, which is neovascularization. And there is some support on literature with transpupillary therapy as well as PDT. Again, very limited benefit with these treatment because we know that these treatment can cause more damage in these particular cases. This is just a summary of the available treatment which people have tried, which we already discussed about it. So we will just move on to the emerging treatment, which is very much we are going to talk today about the neuroprotective agent, and we have been talking about neurodegeneration. So before we really get onto the treatment, let's try to dig further into the CNTF, which is playing a very important role in maintaining the retinal cell growth as well as protecting these neural cells. So CNTF is pretty much naturally produced by neurons and Muller cells, which we spoke a little bit a while ago. And we understand that because of this CNTF, there is a protection of cone photoreceptor as well as cone outer segment regeneration, which we just showed it on OCT as evidence of neurodegeneration. So now you understand that the CNTF is playing a role in neurodegeneration, particularly in this disease. So why don't we just inject CNTF and prevent progression of this disease? But the challenge becomes because injecting CNTF, it will degrade very quickly and it would not be very efficient for the long term. And that is where this very interesting encapsulated cell therapy came. And I was just talking to folks that it is interesting to see that, I saw this ECT 15 years ago when I was a kid, not a baby, but I was a kid, and I was very impressed with this technology that, wow, you can actually, make your cells express what you want them to release. And this is what the ECT technology was put into an implant, which is being licensed by Neurotech. And they primarily have these bioengineered cells, which has the ability to release CNTF into the eye. And this is an implant which we have to sew inside the eye. And this is a very straightforward surgical technique. We have multiple implants being secured inside the eye in the same fashion for Retisert and other. So this is a surgical procedure, but pretty much straightforward. And this meeting is very timely because just this month, Neurotech got approval for this implant called Enselecto. After getting results from 2 phase 3 trials, which is their molecule is called NT501. I'm just going to show you the trials results very quickly because these are very complex trials. But what I loved about these trials is that they did not focus on the vision, because what you learned so far is that vision is not very much affected in this disease, but very much there is a decrease in the retinal sensitivity and the damages to the outer retinal structure. And the outcome measure of these trials was very much focused on easy area loss as well as the reduction in retinal sensitivity. And for FDA trial, you have to run 2 parallel trials. So this is NT-MT038 trial, which clearly shows a significant reduction in easy loss, which is an ellipsoid zone area loss. And there was definitely a benefit on a retinal sensitivity as well. And the similar results were noted in the B trial as well, where you can see that there was a significant benefit in terms of reducing the easy loss as well as reducing the loss of retinal sensitivity compared to the sham arm. When we talk about adverse reaction, as you can see that there was a very minimal adverse reaction, very much related to the surgical technique. There was some cases due to suture-related complication. There was a case of vitreous hemorrhage, but very much within, I would say, acceptable limits to a surgeon. I would say that these are something which we usually see in our clinical practice as well. So very safe data. This is another data set which was published last year. It's the phase 2 data of CNTF trials, where they showed that there was a benefit of almost 31% reduction in progression of neurodegeneration. There was benefit in terms of the photoreceptor loss. There was a benefit in retinal sensitivity. So here you are seeing that this is a very unique trial. Unlike visual acuity gain, we are talking very much about prevention, or I should say the reduction in progression of neurodegeneration. And these patients, they really require a much long-term treatment. And I should say one of the very important outcome of one of the papers which they showed in their ARVO poster, that even in the animal models of almost 15 years, there was a release of this drug. And this is really encouraging that once you put this implant into our patients, we are pretty much securing them for the rest of their lives.
Thank you. So I'm going to make you maybe repeat yourself a little bit, because I want to point out a couple of very explicit things, almost like take-home messages from what we've been talking about. So I want to go back to a slide and ask you about this. So these things are not mutually exclusive, right? So if somebody has MacTel, they have potentially both non-neovascular and neovascular causes, correct?
Yes.
Okay, so it's not one or the other. So anti-VEGFs will have some benefit, but they don't treat the neovascular,
yes.
Only
when there is a neovascular component. So if somebody asks me that is there a treatment for non-neovascular MacTel, I would say no, nothing works. But what do we do with our patients? So we just follow these patients. We see them progressively losing retinal cells. The retina is thinning out. They are losing vision. We are not able to do anything unless there is a formation of subretinal neovascularization, which is a complication of MacTel, and that is a stage where we start treating these patients with anti-VEGF. But we are only treating the neovascular complication. We are still not addressing the primary pathology, which is MacTel. We are just treating the complication.
Okay, perfect. So I just wanted to point that out, because I think that's an elevator pitch for payers to help understand this. So there is definitively unmet need here. Yep, no
Absolutely,
treatment.
no treatment.
So when I was looking at the data as well, and thank you for summarizing the data, one of the numbers that jumped out to me was the new drug preserves photoreceptors up to 56% compared to sham. So I'm just kind of curious, again, with this baseline, how does that compare, again, assuming we're talking about a mixed cause here, how does that compare to, say, the anti-VEGFs that treat part of this? And then when we say they're not effective, we're literally saying not effective, right, at all? For the non-neovascular
yes.
part of this. Okay.
So yeah, this is a very important question, and I can say that this would be something which we will learn as we start implanting these implant, and then we follow up these cases. Because when the neovascular complication happens, it actually happens in the last stage of the disease. So because we never had any treatment to prevent the progression, so probably these patients actually ended up having neovascular disease. So the benefit of offering this implant very early could be that we probably are going to prevent the complication of neovascularization. So there is a possibility that eventually we may actually not only prevent the neurodegeneration, we actually will be avoiding some late stage complications as well. So you are not only treating the disease early, but actually preventing the long-term complications.
Thank you. All right. So again, I think pretty good data there. So this is the other thing I wanted to ask you about, again, just for the sake of summary for the audience, is this is an implant. So one of the questions that a payer is going to ask is, how long does this last?
The FDA has approved on the basis of 2-year data. So, but I think that this, I remember one of the Harvard posters, which they showed that in animal models that the implant was still releasing CNTF up to 15 years. Okay. Which is very encouraging, because that means that probably these cells, this is what the beauty of this technology is, that you have already bioengineered the cells. Their job is to keep releasing CNTF. So I think that this is pretty much going to be one and done kind of a treatment.
Perfect. So we talk about gene therapies and other things, and those really have not shown to be cures, and they're not one and done, and we're having all kinds of problems with that. But 15-year potential, at least 15 years with this is pretty impressive.
Yeah, this is from the animal data. I cannot promise the human data.
Okay, yeah, but it's intriguing.
I mean, I'm glad that FDA did not wait for 15 years.
Yeah, there you go. So it's very intriguing. Okay, perfect. Now we're going to move in and talk a little bit about how we can work together and focus on multidisciplinary care approaches. I kind of teased out a little earlier. And I'm going to jump in. I'll give the payer perspective here. But again, I want to ask you, Dr. Chhablani, to start is, from your perspective, and we talked about this a little bit earlier, but what are the key disciplines that are involved here? So again, we've talked about maybe primary care physician and others, but really who's involved here?
I would say that because this disease has such a strong systemic association, so we definitely have to encourage our endocrinologists, cardiovascular specialists, where they are seeing these patients and they probably these patients are complaining of some vision changes, or they are not being referred to their optometrist. So I think very much needed is the endocrinologist, cardiovascular disease specialist, as well as optometrist, PCP, ophthalmologist. I think every level has to be educated about this disease. That is where we will be able to bring these patients sooner and offer this treatment and prevent the long-term vision loss.
Perfect. Again, we're talking about eyes here, so this is a super important topic. But we're talking about model for this coordinated care. There are a few goals that we just want to talk about. And I'm not going to read this slide. We'll leave this up, and as we talk about this, you can read through this. Goal 1 would be to enhance detection and diagnostic capacity to enable early intervention. So how long would you guess it takes somebody to be diagnosed with this? We're talking years, right? And you mentioned a lot of misdiagnosis.
Absolutely. Years, literally years.
Okay, so better education, better diagnostic criteria, more awareness, that would be goal 1. Goal 2 would be to alleviate treatment burden on patients and health systems. So that's, again, appropriate diagnosis, appropriate care, outcomes will be better, access is an issue. Goal 3 would be to enable better monitoring and management of individuals with retinal disease. So again, this is part of quality metrics, a part of care management programs. So if our patients have diabetes, for example, and we're managing these patients, and we should be managing them for quality perspectives, and retinal screening is part of that. And now we have something else to look out for here. And it's important that we understand this, because as we've, again, hopefully been not super repetitive, but there are different approaches here. So we have to understand that. So it really is about the right drug to the right patient at the right time. I don't know if you have any specific comments on this slide.
No, I think the only thing I would say that, the sooner the patient is seen by optometrists, nowadays we have such great imaging tools, and, we are trying to educate our colleagues as well in ophthalmology and optometry, where we will be able to diagnose these patients much earlier just by doing imaging, and, sooner we diagnose, the better treatment options we have.
Perfect. And what is the prevalence of MacTel relative to, say, diabetic retinopathy or AMD?
The literature says it is 0.1%, and I would say because we never knew about the disease, that's why the prevalence
just
was
don't know.
less. Because these prevalence studies are very much based on either clinical exam or color fundus photograph, and these diseases, this particular disease, it can be missed on clinical exam or on color photograph. That's why you need a little bit high resolution imaging such as OCT. So I think that these numbers will change eventually, but at this point we know it's 0.1.
And it's the same provider who is treating diabetic retinopathy and
Yes.
MacTel and everything else,
Yes.
right? Okay, so where I'm going with that is this is not super prevalent, but the doctors here are going to be the experts. And at the end of the day, we're going to know who the doctors are that are treating our patients and our members with MacTel. So there are opportunities. We're not necessarily going to talk about those here. We've talked about them in other programs when we've talked about AMD and DR. Is there things we can do? We're going to have to prior auth drugs. We have to prior auth drugs because our employers expect it. But again, it's about appropriate use, appropriate patient at the right time. So there are things, though, we can do. Since we're going to know who these doctors are, we can talk about gold carding, and we can talk about reducing the artificial barriers that exist in the system to make sure that patients have access to this drug. Because I think the data is very good, and again, this is pretty durable, and we don't really have options here. So if a patient has this diagnosis, probably need the drug, so we need to make sure that we're not an artificial barrier in that process.
Absolutely.
So what would you say to a payer? So we have a new drug now. We don't know a lot about this disease state. Again, we're going to have to prior auth things. We prior auth all of the anti-VEGFs. What would you say to them to help them understand what is best for the patient and would help you appropriately treat them?
I think the first thing is we don't have any treatment available. The second thing is that the sooner we treat this disease, the better outcome we have. And I would say that, this is more like, one and done, which is again a biggest benefit for our patients. So I think that the payers should understand that there is no other treatment available, and this treatment seems to be very durable. And delaying the treatment may not give us really, because unfortunately, even when you offer this treatment, you are not able to bring back what you have lost. So the neurodegeneration, which is already is there, we are never going to revert it back. So sooner we offer this treatment, the better outcome we have, and we will be able to prevent the long-term vision loss in these patients.
Earlier treatment here is crucial.
Yes.
Right? Perfect. So this is where I'm going to come back to again and just kind of summarize the role of the payer. And I think the payer has a responsibility here. So again, we're the ones that are managing the patient across the spectrum. So if they have diabetes, if they have cardiovascular disease, they're probably in our care management programs, especially if they're using resources. So we need to make sure that we are appropriately screening and not putting artificial barriers in. But how we use that data is important. So our doctors generally don't know if somebody's non-compliant on their medication. They don't know what other doctors they're seeing. So that's an opportunity for us to coordinate that. But we have to do it in collaboration with the physician. And I think that's another important point is these patients can probably be overwhelmed, right? They're getting a diagnosis. They're talking about vision being affected. They're probably scared. But then what we don't want to have them is overwhelmed when they're getting, they're working with the provider. They're probably getting a call from the payer. They're, who knows where else they're getting information from. So my personal opinion is that is a role that we should step into and do a better job of coordinating that, because we can provide information to the different stakeholders that are involved here, but it has to be coordinated.
100%, and I think that is what we saw even with the anti-VEGF therapy, and now we don't have any issue. Means there are other issues with anti-VEGF therapy. So I believe that if we get a similar support from the payers, it would be a pretty straight, I would say, much more helpful for our patients.
Awesome. From your perspective, from a provider's perspective, how would you kind of summarize the barriers that you see in your patients to appropriate access?
I think that the first barrier, like we discussed on a couple of times, is the early detection. And I think that the second barrier is obviously especially for the low socioeconomic group, where they don't have access to the physician, to the treatment that could be there. And, I think that one of the biggest challenges we are facing is that the doctors are overwhelmed and we don't have appointments available. Next appointment is available in 4 months. So I think that a telemedicine approach, I do a lot of telemedicine because many of these patients can just get an imaging and we can talk about the disease and, discuss about the other opportunities, what we can offer them. And I think the biggest barrier in this disease particularly is the education. I think educating the providers, PCP, optometrists, endocrinologists, and then bringing these patients to the clinic, particularly the low socioeconomic group, which always faces this challenge in terms of the access. And if we have great support from the payers, then I think that as soon as we define the disease, we can offer the treatment. This could be streamlined.
Thank you for that. And I'm glad you brought up inequities. So we talk about that a lot. So right now, really hot topics in the industry are population health, social determinants of health, inequities, those types of things. And we deal with this a lot. Again, going back to AMD and DR, this is a little bit more intriguing to me because I'm based in Salt Lake City. We have a lot of rural lives in Utah and surrounding states. And so you just access and having to drive in and get drive a couple hundred miles to get an injection every potentially 4 weeks has been a problem.
Yes.
So this is intriguing to me because it's a one-time, approach, and then hopefully it lasts for a long time. So that should help that a little bit, but there's still going to be access issues, right?
Yes. But I think that what we are doing at UPMC is that we are trying to set up these remote imaging centers where we can actually have satellite centers where the patients are getting imaging done and they can just follow up with us. But like you mentioned that, yes, we also face the same issues with AMD patients where they really have to drive 1.5 to 2 hours just for one injection. And I think that a treatment like this could be beneficial in that regards.
The other thing that comes up a lot is telehealth, and I'm just kind of curious how that could be utilized here. With all the technology we have and screenings and things like that, how can that be utilized to maybe improve outcomes here, if at all?
Telehealth is, I think that thanks to COVID that we learned so much about telehealth that, it has become really an essential part of our system now. So what we are doing at UPMC is that we have these multiple satellite units where we have imaging facility available. So the patients get imaging done and then we call them and talk to them, or you do video call, show them how the imaging is, that if you want to bring them to the hub, we can do the treatment, or they can follow up just by remote imaging. Particularly for the screening, I think that now we have these fundus cameras available, and because of the DR screening or AI-based DR screening, there are multiple PCP offices which is now acquiring these fundus camera. I hope that we will be able to really find these MacTel patients as well, because many of these AI-based DR algorithms are also trained to diagnose any disease other than DR. So there is definitely a potential where we will be able to expand this AI-based screening on other diseases, such as MacTel.
Yeah, the other hot topic is AI. So yeah, how we can leverage that is going to be fascinating over the next few years. How homogeneous is the progression of MacTel in patients? Is it very variable, or is it pretty similar across patients?
I wish I could predict.
Okay.
It's very variable, and it's surprising that some patients they don't progress for 2 years. Some patients they progress faster. So like you understand that we have more interest in understanding this disease. So now we are trying to look into finding the predictors which can actually help us to predict that which patient is going to progress faster. Something similar what we are trying to do in GA. So many of the long-term studies have been done in MacTel, but still we don't have any clear predictors, but the disease could be variable. But many times this question is asked to me that, so which patients are we going to really offer the treatment? So at this point, FDA is approving early easy loss patients. So on the basis of imaging, we will be able to identify these patients and offer them treatment.
Okay, that's kind of what I was wondering. It sounds like regardless, if you have a diagnosis, you want to treat, right? Because again, we're talking about the eye. We're not like waiting until it progresses or something like that, right? Okay.
I'm in favor of doing early treatment because we know it is much safer and the long-term benefit is obvious.
Okay. Yeah, I was kind of curious if there were like patient characteristics around education or income or other things that would maybe influence that, but it sounds like that's not a point because we're trying to, again, preserve.
Yes, as much as possible, as soon as possible.
Okay, perfect. I think our last formal section is around benefit design strategies. Again, kind of been going over this here, so here's a little bit more data just to kind of wrap this section up. So we talk about cost and insurance. I'm just going to read some of these statistics. Approximately 78% of participants in a cross-sectional survey by Ada and colleagues a couple of years ago cited high medical costs or lack of insurance as a barrier. That was the number one choice by the audience here, so pretty consistent. Transport and accessibility, we've talked a little bit about that. So, but I like that hub approach too. And again, I think the benefit of this drug is it's one time. So we can make this more convenient and less problematic for the patient and really only potentially bring them in maybe just for the treatment itself. Yeah. If we can leverage technology and telehealth and those types of things. Yeah. Literacy is obviously important. And again, I've been hammering on this for the last 45, 50 minutes around communication and this collaboration. So we don't want to make it worse for the patient and our members. We want to educate them and make it as easy as possible for them. But they're going to be seeing a lot of different people here. A lot of different providers are going to be dealing with insurance issues and things like that. So we just need to make sure that communication to the patient is not overwhelming and it's very clear. So benefit design strategies. This slide outlines some of the work that Impact Education and AMCP have been doing in retinal diseases around payer best practices. So this list was generated from a roundtable discussion on wet AMD and then prioritized by chief medical and pharmacy officers in a separate program focusing on improved care for all retinal diseases. I was part of this, but the point here is that this was literally targeted at decision makers. So these were chief pharmacy officers, medical directors, ones that were managing formularies, setting strategy. And what we saw here is that the points that came out of those meetings were we need to do a better job of facilitating timely access to appropriate treatment, encourage screening and advocate for incorporation in the quality measures, consider value-based agreements. And I don't want to go off script here a little bit, but to me, right, we talk about value-based care a lot, and I think the model is finally changing. We've been talking about value-based care for a long time, and I'm not necessarily talking about value-based contracting per se, but value-based care rather than fee-based care is something that we should all be focused on. And I think we're going to actually see a lot of this coming out of Washington over the next 4 years as we kind of figure out what's going to happen in healthcare with the new president and the people that are really he's bringing in to manage healthcare. But value-based is going to be super important here. But if we also are talking about an opportunity to collaborate with pharmaceutical companies and payers, is this, again, this idea around helping us understand what the exposure is and how long this is going to last. And maybe there's just a conversation to have there with the new therapy. But again, gathering multi-stakeholder input's important and embrace appropriate new technology. So this is really the first drug we've had the first drug we've had, period, in this particular disease state, but the first drug in a long time that's not VEGF in just eye care in general. So it's pretty exciting. Does this align with kind of what you would say are maybe the opportunities or the strategies that we should be looking for in this disease state?
Absolutely, and I think each of them really fits well what we have been discussing for the last 40 minutes.
We are now at the point for questions of Dr. Chhablani, and I'll help facilitate that. Maybe I can ask you one kind of final broad question, and that is, what are you most excited about when you think of how you can help your patients with MacTel?
I think this is very exciting because we never had any treatment option, and it is very frustrating for the physician as well as the patient, that you have a disease, you have progressing disease, you are seeing them every 6 months. Why are you seeing me? That's the usual question they ask. Why are you seeing me when there is no treatment? And because of imaging, we had the chance to see the progression. We tried many things. Does vitamins work? No. Should I do anything else? But nothing works. But this is very exciting that now we have something to offer. And I've been talking to my patients for the last 1 year. And I've been telling them as soon as we get hold on this, we are going to jump into this treatment. So I'm very excited because there is something which is scientifically proven, which is working so well for up to 2 years, and the animal data clearly shows the long-term benefit. I think that this is very, very exciting for both for the physicians as well as for the patients.
Awesome. Thank you. What role do you see for the pharmacist or pharmacy department in managing this drug/device? I think there's a lot of opportunities. The biggest is making sure that the criteria we have around this drug is appropriate. So we prior auth pretty much everything nowadays, so there's going to be prior authorization. We want to make sure that that's appropriate and not too egregious. And like we said earlier, how I would summarize this is not going to be very prevalent. We're going to know who the doctors are that are treating this. We should have a relationship with them. So we want to make sure that access is not an issue. We're not an artificial barrier. The PA is not too egregious. And then I think the other thing is, not to be super repetitive, is our role in coordination of care. So we're the ones that have the data. We know what these patients are doing and not doing, and we can better inform the providers that are involved in treatment so that they can better interact with our patients to, again, educate them, make sure they're coming in when they're supposed to, make sure, whether it's screening, treatment, whatever. So I think we have a lot of opportunity here.
Absolutely.
A question that payers are going to ask, and I want to clarify this. I want to make this overtly clear. So the question is, would a patient with neovascular disease need both anti-VEGF and the implant to manage the disease?
We don't have the data, but I believe we will need, because the implant is going to treat the primary pathology, which is MacTel, and anti-VEGF is very much for treating the neovascular component. With time, we will learn that how many of these patients with implant eventually turn into neovascular disease or they remain non-neovascular, because I hope that the progression of the disease is delayed so much so that they don't convert into neovascular. But at this point, I would say probably we'll be requiring both. Great question.
And payers are going to ask it, so thank you for asking that question. All right, the next question is, what's one thing you would encourage payers to consider as they review this treatment? I'm kind of curious what your answer to that would be. What would you tell a payer to consider? I would say, again, we're talking about eye and vision, and this is something we need to get out in front of, and it's not going to be super prevalent. So it's unmet need. We do not have anything that treats this disease state. So it's the efficacy on top of unmet need. That's what we need to understand, and we should not be putting artificial barriers in place.
Jeff, I will just add one more word here, is the irreversible vision loss.
Thank you. Yeah, we're not getting this back.
Yes,
Yeah.
because once you have irreversible vision loss, then you cannot bring it back.
Do you see a role for the doctor or the plan to reach out to the patients directly to tell them to get evaluated for appropriate new therapy? So I'll admit, I think I have some payer colleagues who are not going to be excited about reaching out because they're going to say, I'm going to have to pay for something and I'm not, blah, blah, all the stuff that we talk about. But I personally think that is our role. Again, if somebody has diabetes, if somebody has hypertension, if they have, they have these things, we know that at some point they're going to have some issues with their eyes.
Absolutely.
So, and you very eloquently said, prevention here is key. We don't get this vision back. We need to get out in front of this. And I don't want to, again, I'll just throw out there, I don't want to hear this, well, we're not going to have this patient in 15 years, all of that. And that drives me crazy when I hear that. So I absolutely think that, again, with patients with these very commonly well understood comorbidities, we do have a responsibility to make sure these patients are being screened.
And we really appreciate that part.
Okay.
Yeah, we can only treat the patient when they are with us.
Since we have Dr. Chhablani here, I want to ask you, now that you have the therapy to treat this, and you want to treat them early, right, so they don't get irreversible loss. But you also mentioned that these patients don't even know that they don't notice any difference in their vision. So if you detect that they need the product, doing an implant in your eye is pretty invasive. So do you anticipate patients that might be reluctant even though they should get it? And how do you handle that?
Very good questions. So there are patients who are asymptomatic, and if I can correlate it with their OCT findings, I would say that patients, those who have disease and asymptomatic, they usually don't have significant structural damage. In that stage, I would like to educate them that you have MacTel and there is a chances of progression. And if we see any signs of progression, then we will have an option to treat you. And this is how I'm going to start the conversation. If I have a patient who is already symptomatic and there is already structural damage present, then it would be a much easier conversation because they have the symptoms and we can see the changes. And this is something which we are facing even with patients with GA, and we are like literally going back to their optometrist, trying to get all their previous imaging and showing them on the pictures that you can see here what is happening every 6 months, there is progression. So if this keeps happening, you will lose much more vision, and then we will not be able to revert back. So that would be the stage where we will be able to convince the patient that, this is the time where we can stop the worsening. So there will be a lot of discussion with the patient, but I can tell you that I have already so many patients, and patients are much more motivated for something because they know that there is no treatment. And we have such great imaging, we are able to show them what is happening on your pictures, and this is how your 6 months or a year ago the OCT was, and here you can see there's difference. I understand that there will be more functional tests which we will be incorporating in our practice, which will again establish an objective role for such treatment. But there will be a lot of conversation. And the best part is that this is not something which we have to do tomorrow. We can have the conversation, come back in few weeks, we talk about it again. We have more data coming in, more confidence, and I think you guys know better than I know that patients are very smart. They know what to look for. So they are already reading about it. They already know much more about the drugs what we know.
So I'm going to make an attempt at kind of summarizing my 5 or 6 take-home points, and then I would like to ask you if you have a difference of opinion or have anything to add. So if I'm talking to a colleague about this, and this is, again, probably going to be a new disease state for most payers, this is what I would kind of summarize. And I've been writing this down as we've been going along. So one is the comorbidities. So that, again, that's important because it dovetails into what we're doing around quality, what we're doing around coordinated care management, integrated care management, those types of things. The second would be this issue of non-neovascular versus neovascular, and how that potentially leads to a lot of misdiagnosis. But we also have seen an unmet need. So we have therapies to treat the neovascular component, but we've had nothing to treat the non-neovascular. So we're potentially talking about polypharmacy here, but really, we now have a drug that treats the non-neovascular component that we didn't have before. And the third one would be, again, the importance around multidisciplinary care and how we coordinate that, because these are going to be very complicated patients given all of the other comorbidities. Anything to add to that?
Just early detection. Early detection is the key.
Okay.
Yeah, that's all. You covered most of it.
Perfect. This is a new topic for a lot of us, and to me, it's exciting. And we have a drug here that really, truly fits an unmet need. And I will just, again, go off on a tangent in that this is an important an advancement. So I was talking to, again, not to unblind or anything else, but I'll just keep this very high level. I was talking to a manufacturer about a drug that's coming out for a rare disease, and the benefit was actually reducing the amount of steroids that we're using. So it didn't really talk about treating the disease or modifying the progression of the disease or anything else, but because it was rare, they were talking about astronomical potential costs of that therapy. And it kind of frustrated me a little bit. So here, again, we're talking about a drug that is now, that we have, that we didn't have anything before, and the data is really good. And so I think in the value prop is there, and my take home would be we as payers need to educate ourselves about this disease state and do everything we can to make sure that patients have access to this medication. All right, Dr. Chhablani, I would like to thank you for all of the great information, and also thank all of you for being here. One last time, I would like to thank Neurotech Pharmaceuticals for their independent educational grant, and also PACE and our friends at Impact Education who make these programs fantastic and make our lives easier in order to educate ourselves and get CE. So thanks again for being here.